Hey folks, we're back. I'm your host BKP. We're at Circuit World here in Blue Ridge. For us, it's a beautiful Friday morning, period. We're leaving it right there. It's time for Ask the Doc with Dr. William Whaley. This is brought to you by Georgia Cancer Research Center, affiliated with Northside Hospital. How are you this morning,
I'm
Dr.
great. Yourself?
I can't complain. I'm doing very well.
Yeah, and it's a beautiful day. We're behind in rain. And Jane said if I said anything about us being behind in rain, everybody would think I was crazy. But if you go to the, please, it's a communist newspaper, but if you go to the Atlanta Journal-Constitution.com, every day they have an almanac that tells you when the sun's coming up, when the sun's going down, and
right.
We are behind by 0.16 inches in rain for this year. 0.16. Now that's not much, but we're behind a little bit in rain.
Well, I don't think that's the part of our segment, but I do want to say, for those gardeners out there, I think it's going to be a good season.
Jane says
the ground is moist.
The cows are getting hoof rot because of the rain. And if I said something about it, it'd drive them crazy. But anyway.
Okay, well,
there's your weather report on Fetch Your News. There you go. We got a dog in our house who went out this morning. When I get up at 5:45, we call the weather dog because it doesn't do anything if it's raining. Came right back in, and I didn't even have to look out to know it was raining and the dog was wet. Okay, go ahead. That's the weather dog.
Okay.
You've heard of the weather dog, right?
Yes.
Okay.
So we have done our weather dog report. Fido's weather in the mornings, right here. Let's move on to our first question, Dr. Whaley.
All right.
My grandmother was recently diagnosed with
Ocular melanoma.
Melanoma.
Okay.
Ocular melanoma. Say that 3 times. Ocular melanoma. And there is very little written about it. Will she go blind because of this? Where do you
recommend me
recommend? Where do you recommend me looking for more information on her type of cancer?
All right. Well, I'm going to hit the information question at the very end. I do want to say, BKP has always been good about saying, with many diseases, how old are you, what's your family history, what are your comorbid conditions and all that. Unfortunately, when you say ocular melanoma, it's like saying, a question saying, my mother has a painful joint. What should she do about it? Well, you got hundreds of joints, all over your body. So BKP, put up that first one, Josh. It's got that big old long chart here. This is a 3-page long chart that they're only going to show you the 4-page long chart. Actually, they're going to show you the first page of. But it just begins by talking about 2 parts of the eye: the choroid, the ciliary body, and you'll see that it's about 20 lines long, and each of these is about 10 lines long. And each of those represents a different part of the eye. So the next question, the next one you're going to see here, you pull that up and put this cross-sectional picture of the eye up. You got that up, Josh? I hate to tell you, but look at that boy right there. That eye's got a whole heap of parts to it, doesn't it?
Sure does. Don't start asking me to.
Well, you're not going to have to tell you any of those words, but the eye is made up of about 30 different parts. Of those 30 different parts, at least 5 have got melanin in them and can have melanoma. So when I look at your eyes, let me look at your eyes real good. Okay, well, you got sort of grayish eyes, and I got sort of gray-green eyes. That very first part of the eye is called the iris. And then right behind it, since the iris gets big when it's dark, right, and gets small when it's bright, there's a muscle back there called the ciliary muscle. And then you got this big old retina back there in what's called the choroid. And then you got all of these things in the middle and the macula, which has got all that stuff. So you can have melanoma in many parts of the eye. Show that next.
So when you just say ocular melanoma, that could be in about 5 different areas.
Yeah, that's what.
Okay.
That's a big deal here. So I'm going to show the next one here is really simple. If you go look at Josh, you got the next one up there. If you look at Josh, you don't have to be kissing him or anything, but if he's not wearing glasses and he hadn't got his hat on and his eyes are wide open, you would see that thing right there that's blotting out part of the eye. Right. Now, that's an ocular melanoma that's occurring in the iris, in front of the iris, so Leroy can see it by just talking to you. That's less than 0.1% of the ocular melanomas, however. So you can't depend on that for making a diagnosis. Now, just leave that up there, because you want to get into vaccinations? No. You want to get into colonoscopies or mammograms or any of those things? No. But I repeatedly say that after you have reached a certain age, you ought to have your cholesterol checked. You shouldn't wait until you're clutching at your chest with coronary disease to learn that your cholesterol's high. You need to lower it, right?
Right.
I get people all the time that have got colon cancer that have never had a colonoscopy, and they're 65 years old. So I'm going to tell you to go get a colonoscopy. Now, when we've been talking in the past, I have said that you need to go get routine eye care that has nothing with whether or not you lost your glasses, you know? I mean, we talk all the time about you can't find your glasses and you can't read this and I got to read it for you. So you should see an eye care professional at least by the time you're 30 years old. And between the age of 30 and maybe 50, you need to go back every 3, 4, 5 years. And sometime around age 40, you're going to get to where you're having trouble with the small print like that. And then I don't care if you go to Walmart and buy your glasses to correct that print, but you cannot diagnose pressure diseases without having to go to the ophthalmologist until you start to turn blind. And you cannot diagnose retinal diseases unless you look in the eye until it starts affecting your vision and you are going to turn blind.
What are the two things, cataracts and what else is?
Cataracts.
I'm not talking about cataracts. I don't want to go there. I was just
glaucoma,
glaucoma,
pressure, and then retinal diseases, which can be blood vessel diseases. We've talked about macular degeneration, macular proliferation. Well, ocular melanoma, 90-something% of them. Okay, let's show that next picture there. That next picture shows a cross-section of the eye. That whole back thing right there, that's the window, that's the screen. You got that one up, right? That's the screen, that's the retina, that's the choroid. Oh, at the bottom of that, you see that melanoma, the ciliary body there?
Right.
That's a melanoma that you can actually, you can't see that one. The first one I showed was of the iris. That's the front part where you can see it. This next part there, you would know that happened because your iris wouldn't work anymore. So that would be another symptom that would get you in, or you might say, hey, wait a minute, one pupil of yours is big and the other one's small. Somebody's gonna notice that. Hey, wait a minute, that pupil right there doesn't change. You know that a lot of times Jane says, your pupils aren't equal. I said, that's because of bright light over here. Go to that next one. It was the next one I wanted to show. That big long cross section of the eye. So this whole big thing right there is your 360-degree screen. That right there is the choroid and the retina, and the pigment in there is melanin. I think I told you not long ago, I've had a melanoma of the arm. First thing we do after we're trying to figure out if melanoma spread anywhere is get those people to go to an ophthalmologist, get their pupil dilated, and let them look at the retina. Because that retina, if you've got an early spot back there, you can diagnose that way, way in advance of it doing anything to you. You remember that great big old chart I was showing you here a little while ago that had 3 big pages? Okay. The survival. She wanted to know, are they going to go blind? The survival depends upon how thick that melanoma is at the time of diagnosis and how wide it is. And many, many, many melanomas you don't treat. It's observed from, I told you I went back every 3 months for photographs of my retina, then I went back every 6 months, now I'm going back every year, because what's in the back of my eye is a pigmented melanonic spot doesn't have any vertical dimension to it, and so you don't know if it's a melanoma until it starts to grow, and you go, okay, that is a melanoma, because you don't biopsy it, but it's way back there in the back of the eye. So this going to see an ophthalmologist, having that ophthalmologist dilate your eyes, look at your retina as a way of making early detection is mandatory. Now, this question did not say grandmother was having trouble seeing, might have been her cataracts, might have been her glasses weren't too good, and went to a routine eye exam and had a very early melanoma that they're not even treating. Or she began to have big holes in her vision and began to have flashing lights or something from that melanoma messing up the retinal response, and she went into the doctor with a complaint, and at that point you would think the melanoma is somewhat bigger. So basically I'm going to make the discussion about the common type of melanoma. That's on the retina. That's 90%. The front part, the ciliary body, and the iris is less than 10% even in the aggregate. And the survival of ocular melanoma is really quite good with modern treatment, which I'm getting ready to show in a minute. But a period in the early 70s when West Paces Ferry Hospital was in Atlanta, I think I mentioned once before, the high volume eye and ear, nose, and throat doctors in Atlanta combined to build a hospital that right now Arthur Blank's building is on, and it was called Metro Eye and Ear Specialist Hospital. So the first retinal surgeon in Atlanta was Jack Davidson. He's still practicing. Second was, who went to this practice? Anyway, they were the only two retinal surgeons in the state. So they had all the ocular melanomas. I mean, if it happened down in Savannah or Waycross, the doctors would send them up there to Jack Davidson and Scott Lampert, his partner. Well, I was the cancer doctor across the street, so I actually had 9 out of every 10 ocular melanomas in the state in my practice for about 5 or 6 years. At that point in time, the forward crest of the wave I've talked about before, there are people who specialize in various diseases, though the two people that were specializing in this disease were the Wills Eye Clinic in Philadelphia and Miami Eye Clinic down in Miami. And so all the ocular melanomas in the whole United States got sent there to show that next one. Now, this is going to make you do a little bit of this. So you look at that real close, Josh. You see that? All right. So you see, that's your eyeball right there.
Yeah, I got it.
It's making you a little bit uncomfortable, isn't it?
Yeah.
All right, this is a disc. It's actually gold with radiation in it that has to be built by a computer so that the radioactive isotope and source focuses all this radiation right down on to wherever in that whole big old, 270-degree circle your tumor is. And then it's treated with this plaque placed on your eye of radiation directed right to the spot. Now, you would think in the Bible it says, if thy eye offend thee, where's the Bible student here? What's it say in the Bible? If thy eye offend thee, come on, where's the Bible student? Pluck it out. Okay.
I actually just did not want to say it.
That's what it says in the Bible. I offend thee, plug it out.
Yeah,
so,
I didn't want to say that.
Historically, before the Wills Eye Clinic in the late 70s and in Miami in the late 70s and early 80s developed this treatment. The treatment for ocular melanoma, once it was diagnosed, was pluck out the eye. So in the early period of this time that I was involved in the therapy of ocular melanoma, the treatment was remove the eye. If it's not too big, that's certainly a great treatment because it's gone, right? Now, if it was deep, then the chances of it recurring were pretty good. Or it's not pretty good, but the chances that it could recur were real. So this therapy allowed you to preserve your eye. I have patients still today, saw one a couple of days ago, treated with this treatment about 8 years ago. He has functional vision in that eye. That means he can't read that license tag out there. But with that eye, he can see them over there. He can see movement. It makes it easier for him to drive. And so it's preserved vision, not good enough to if it was his only eye. I told you a few weeks ago, people with one eye can fly. If that was his only eye, he couldn't get a flying certificate and he could not drive. But it still adds to him. So doing this treatment has the equal survival to plucking out the eye, which why it makes and it preserves vision. When you've plucked out the eye, you don't have any vision. And that's equivalent to, we can take out a lump now from a breast cancer and preserve the breast at equal survival to having removed the breast and done a mastectomy, right? Mm-hmm. So here, this is the equivalent of a lumpectomy for breast cancer on the eye, and the vision in most people is preserved, and the eye is preserved. Now, the recurrence rate for ocular melanoma totally depends on that chart in how deep the tumor is, and it's all in millimeters, in tenths of millimeters, and how wide it is in millimeters. And then in my practice right now, I think I'm following about 15 patients with ocular melanoma, and I have not had a patient recur with ocular melanoma and die with it in the last 7 years. So your grandmother, we know so little now about what you told me, but your grandmother was recently diagnosed with ocular melanoma. The odds are it's going to be a retinal melanoma. We don't know anything about how deep it was or how wide it was. Will she go blind because of this? Not if they use this type of treatment and it is successful. Where would I recommend you look for more information? All right, so that last one, where's my Mayo Clinic thing here? You got the Mayo Clinic thing? This again is 5 pages long, and I'm not selling the Mayo Clinic. But I don't want you to go on YouTube. Is Jane out there yet? No. Praise the Lord.
Move right along so we don't get
I got to hurry up. Don't get your news from YouTube. Now, Mayo Clinic is going to ask you to make an appointment to go up there. Fine, go up there if you want to. But the MayoClinic.com is a worthwhile place to go. And so I just pulled that one up, and it shows you 20 articles on this disease. The NIH, National Institutes of Health, has a link to public information for every kind of cancer you ever heard, toenails and eyelashes and everything else sort of cancer. So MayoClinic.com, NIH, Harvard, there are lots of places to go for information. Now, is that good?
Yeah, I want to ask something.
Sure.
Well, I know we got to get to the next question, but ocular melanoma, is it always something related to your vision, or is it is it something that if you're having problem with your vision, is it always something related to it?
No.
All right, because
most patients would not have any visual disturbance.
Okay.
They would go to the eye doctor for the routine eye exam requested by Dr. Whaley, and when he dilated your eyes, oh my gosh, there's a pigmented lesion there, we got to watch it. Now, right off the bat, if it's deep, thick, you'd say, okay, that's a melanoma. But I'd say most of the time they say, you got a pigmented lesion, I want you back in 3 months and re-x-ray it. So no, they are not associated with visual disturbances. And that's why I said, if you got the one in the front, which is minor, small in terms of number, somebody can see it. If you got the one in the ciliary body, your eye is not going to go up and down. That'll give you some early detection. Otherwise, you've got to go see an ophthalmologist or an optometrist to get your retina looked at.
Okay, we want to thank Georgia Cancer Research Center, affiliated with Northside Hospital, for this segment, and that brings us to our second question this morning. Diabetes is common in my family's history. I am thinking about starting a family of my own. Is there anything I can do when I have children or when they are young to protect them from diabetes later in life?
It's a pretty good question, and I hate the soapbox. We got to bring my soapbox over here, Josh. I want to stand on it and preach here just a minute. First of all, the question doesn't tell us whether or not your family's diabetes hits people in their teens or 20s, is insulin dependent, and is type 1 diabetes, or whether you come from a family who has a tendency to be above the lean and ideal body weight and has type 2 diabetes that's associated with obesity. So the first order of business is we do not have enough information here. Second, your family's got a mother and a father, so 50% of your genes came from one side and 50% came from the other. So if the diabetes is all on mama's side and everybody on mama's side is kind of generous in size, it may be type 2 diabetes, or even if it's type 1 diabetes, as long as your daddy's side hadn't got it, heads you win, tails you lose, you got a 50% chance that you don't have that gene. And you have not said that you have diabetes. So right off the bat, I'm going to tell you, I think you're worrying a little bit too hard. You need to talk to your doctor a little bit about it. You don't need to go to a genetic counselor, which we have. But in terms of the, oh, and one more thing, the diabetes is associated with, we talked about pancreatic cancer last week, didn't we? That is associated with an increased risk of pancreatic cancer. Now, we don't know whether that's an increased risk of pancreatic cancer is totally linked to the gene, because diabetes, again, as I say, can be related to obesity, and then obesity is related to increased incidences of gastrointestinal and pancreatic cancer. So let's get my 2 soapbox slides up there. What's it say?
7 steps to diabetes prevention.
What's that first one?
Be more active.
Okay, that's that 1 hour walk 5 days a week. What's this one here say?
Lose weight.
Oh my goodness gracious. And then you got eat fiber-rich foods, eat whole grains, blah, blah, blah. And what we don't have that one. That one, you
don't smoke.
Okay, well, you got a plus. So, okay, BKP got a plus.
Drink in moderation.
Yeah, G gets a plus. BKP won't even pass a drink across the table to you, and I'm a witness. I am a witness, all right?
All right.
All right, so, but anyway, there's a couple more down here that on the next one. Show the next one, because I really don't, I'm not so sure that I buy all of them, but this thing here in the Prevent Diabetes is actually for people who have an elevated A1C hemoglobin and are in that group called pre-diabetics, and they're not diabetics. So when they're going to classes now, see, so so Ray Tidman or somebody did a diabetes screening test, and the A1C was elevated, and they said, okay, you're a pre-diabetic, all right? So when you go to that class for pre-diabetes, they're going to tell you to manage stress and
change your lifestyle.
I think I was talking to somebody here this morning who said that they get up at 5 and that they're only getting about 4 or 5 hours worth of sleep on the average day, and occasionally will take a nap. And that actually is important in diabetic prevention, is that you get into that group that's up in the appropriate sleep. That's 7.5, 7.75 hours. So you would call that change your lifestyle. Now, what's this one over here say?
Manage stress.
Okay, stress. I mean, I don't know if anybody here is under stress, but I think there are people in this group, Josh and your associate over there, who said that they got so much stuff going, and they got this thing, and then they got the basketball game they got to be at, and then they got to get up early to get Doug Collins on the telephone or something. So I think that comes under this manage stress. Okay, good. All right, now I'm an ex-Marine and a jogger, so I don't have trouble with this one. What's that one say?
Stay motivated.
Stay motivated. Stay Marine. I can tell you that story one day.
Let me know when you're doing.
That blasted people out there, but anyway, I can tell you the story about stay motivated, stay Marine. That's
Wake up, Jeremy.
I'm over here. He scared me.
All right, now what's this one?
Be positive.
Okay, so we're going to tell this woman that I think all of these things, you can't change your genetics. I have a talk I used to gave it all over the daggum world. It said, life is a 5-card poker hand with no draw. So you were dealt those 5 cards by your mom and your dad when you came out, which is one of the reasons.
Exactly.
That's one of the reasons I believe that life starts at fertilization of the egg. And some guys can win in a jacks or better poker game with a 10 high hand because they can play it well and bluff and do stuff. Well, the genetics you got say stay lean, stay active, exercise, drink in moderation, all the things that are on there. That's going to prevent diabetes in your children. So when that kid's born, you take that cell phone away from them. You don't give them a device. You get them outdoors, and when they get hungry, you feed them a carrot instead of a cheese. What do you call those things? Cheetos. And you give them water, and you just keep them thin, keep them lean, and then you're going to help them prevent diabetes. Now I'm off my soapbox.
Let me say this, because when you started
like my soapbox, right?
Yeah, when you started out, let me say this before we finish diabetes, because it's very important. There is when I go, I don't care to share it, when I go yearly and do blood work, my doctor will say, okay, here's your sugar level, and it can be maintained with diet and exercise. So there's that where you can maintain with diet and exercise, and it is due to activity, weight, stress, all that. But then a friend of mine, his daughter, 13, this is a couple years ago, very athletic family, about 5 kids, mom, dad, very athletic, kids getting college scholarship. All of a sudden at 13 years old, the daughter was having a problem. She's diabetic, and she actually had to have one of those things put on her arm. You understand what I'm saying?
Yeah, got an insulin pump.
That's different, right?
That's genetic.
It is genetic still?
Yeah, that's not lifestyle. That's genetic.
No, that's genetic, I mean.
Yeah, that's what I said.
What I'm saying, you can
can't
be a
prevent
diabetic
that
through lifestyle.
You can't prevent
but
that.
That's
no,
genetic.
No, this is totally genetic. That is totally genetic. Got nothing to do with diet, exercise. Now, let me pull that back. If that kid had gotten a real bad case of pancreatitis from a virus, that then, like mono can kill your pancreas, but it got pancreatitis, they'd have been sick as a blinking dog in the hospital for weeks that could have killed the pancreas, then that would not be genetic. But we got a healthy kid that was healthy and nothing wrong with them, and then they got diabetes. So yes, that's totally genetic.
I want to ask you a question before. At this time, again, thank you, Georgia Cancer Research Center affiliated with Northside Hospital. And at this time, we always give Dr. Whaley an opportunity to share what's new and out there in the medical world. But I've got something I want to ask you, because this past week I listened to a speech from the President of the United States, and because this is Georgia Cancer Research, I say that, and the word research is in there. Okay. These are some of the things that I don't think the administration gets enough credit. How big is right to try for patients, or right to try? How can you? I mean,
yes.
I hope you're okay with me asking that.
I'm totally
right to try.
Okay, I'm totally okay with it. I believe, first of all, let's stay away from YouTube. Where there are phase 1 clinical trials of medications or therapies that have a reasonable expectation of helping people with otherwise morbid or mortal diseases that are likely to take their life, they should be allowed access to them, and their barrier is generally the insurance company won't pay for it. And there's an expense with it in terms of laboratory or whatever. So the right to try opens up clinical trials to the people that are eligible for those clinical trials, and the way it was submitted to the FDA and the approval, they're going to be, this right to try is going to be overseen by, we're the 5th largest cancer group in the country, so it's going to be overseen by this huge investigational committee that has protected all of your privacy and all of your rights, and make sure is what they're doing is as safe as it can be. And I'm all for the right to try legislation, and I'm all for the state of Georgia just passed a law saying insurance companies can't drive you to a specific pharmacy or drug if there's a better one on the market that your doctor wants you to take.
Right.
And that just passed on the last day of the session. So I mean, if you look at that, that's all American rights of people, of our citizens, to get access to the best that's available.
So when you say and when you say to your patient, I want you to take this and this, and then you look at their health care and it says it, oh, it has to push it to this one, you will now, when the governor signs it, be able to say, I want my patient taking.
Yeah. It's hoops you have to jump through, but yes.
Right.
Yeah.
Okay. But no, I wanted to bring that up because every week here I say Georgia Cancer Research affiliated with Northside Hospital, and I know how large the research facility is, and I think Right to Try does a couple things. It gives research centers an opportunity not just to help the person that is terminally ill at that time, but it also helps further the research for your kids, your grandkids, and so forth. I mean, am I on the right track?
You're exactly right. I want to make one more statement. Previously, I'd said that if you're eligible for a clinical trial and you come to me up here at Riverstone, you're going to have to go to our office at Marietta, Atlanta, or Canton for which different clinical research trial, because they're held in different spots. As of April 1st, our clinical research office opened at our Blairsville office. So you're now 18 miles from being able to go instead of having to go all the way.
Oh, that's great. That's great. We need to get that so we can make sure we highlight that. Again, we're running a little behind.
Oh yeah, we got to get to the next one.
But we got to get to that all-star political panel. I can always hear when they get in here. But Dr. Whaley, never want to leave without giving you an opportunity, because I know you look things up.
We talked about the president giving a speech. I am so angry, and I said so last week, when the news, the New York Times says President stumbling gave this. They put a interpretation in the headline.
You talking about when he said his dad's from Germany or something? They said he stumbled in this.
Yeah, or he made a mistake.
Right, I got it.
Clumsy, or
I got it.
Something was wrong. They not present the news. They're putting a slant on it. Well, show that next thing there, which is just this is about this. You don't have to read anything on it, but this is just a list of news articles here. And I almost had a heart attack. I want to talk about Zika and I want to talk about mosquitoes, and I got onto that this morning, and a dadgum article yesterday. Climate change is going to be responsible for dengue and chimichanga fever, in addition to Zika being more common in Florida and in the Caribbean than in prior years because of the moisture and blah, but it began that said climate change is causing it. So it made me so daggum mad. We might have a Zika problem this year. I already said we're going to have a tick problem this year, but when they start saying it's climate change causing the Zika problem, it made me mad as a anyway, a couple more things. That polio-like disease is on the rise. We were talking about measles cases last week. There's 100 more cases of acute flaccid paralysis in kids than there is measles. But it's not something that anybody wants to jump on a bandwagon about. And we've been against vaping. Yesterday you read about the vaping and the seizures, right? We beat them to the punch by about a month on that, and that's enough. We'll shut up and let the all-star panel in here now.
Folks, again, thank you, Georgia Cancer Research Center, affiliated with Northside Hospital. And let me get this out of the way first. If you have a question for Dr. Whaley, please send that to info, I-N-F-O, at fetchyournews.com, and put in the subject line, Ask the Doc, and we'll get it to Dr. Whaley. And as Dr. Whaley always says, he answers all the questions, but the more detail, male, female, age, some of the details in there really help the doctor drill down and give you a good, accurate answer on everything. Send it to us, info at fetchyournews.com. Ask the doc. We'll get it to Dr. Whaley. Also, a programming note, considering Dr. Whaley brought up a new piece of legislation, that's the very good piece of legislation out of the Georgia Georgia legislative session this year, waiting to be signed by the governor. Monday, I always have a post-legislative interview with Georgia House Speaker David Ralston. That'll be Monday at 1 o'clock. We will be doing an interview and talk about the 2019 Georgia legislative session. Yeah, Monday at 1 o'clock. Okay, so we're going to get the all-star political panel in here, and As I always say, don't I say, I wonder if we have anything to talk about. We'll be back right after these messages.